So today we will continue about our cancer, especially cancer screening and diagnosis. So what is cancer screening and why is it important? So we use this term a lot, cancer screening. The issue about cancer is that many times people say, oh, we found our relative found cancer, it's a little too late. So that's always the problem. Early detection is very important. And we are talking about early detection all the time, where technology is very important. So cancer is found early enough when it is small, and then many times it can be curable or easily treatable. Okay, so screening is finding cells do not yet show cancer. What that means is, with the Euiheon explained for this a little bit before. So you don't necessarily have to take out cancer, because cancer by definition, uncontrolled growth, invasion, and metastasis, and you don't want that to happen already. So screening is you want to check whether it's not cancer yet, but it is likely have more chance to become a cancer, then we're gonna go there and then take it out as a preventive measure. Okay, so that we call as a pre-cancer. Okay. Pre-cancer is not cancer, but it's more likely. That's why we are taking out polyps from the colon or GI, gastrointestinal tract. And doctors often treat this before it has a chance to become a cancer. So that's very important aspect. And so this is the part, you don't want to wait till too long. At the time it's already late. So we want to do screening. So I want to go through a little bit of one by one for this aspect. So first, breast cancer.
Professor, slides are not changing.
Okay. Okay, thank you. So yeah, I'm sorry, I've tested it multiple times, and it may be because of the multiple students joining all together, it might cause a problem. Okay, so anyway, we can still go ahead. So breast cancer screening is done with the X-ray mammogram, which I will show you the picture next slide, and of female age of 40 or up. This is more like US standard. And then another big killer for us is actually a colon cancer. So colon cancer is, there are a number of screening tests. I think there are like some of the internal medicine physicians here, so please correct me because this could be changing. So first thing, stool testing for blood. So this year means like every year is recommended. Stool testing wasn't done quite often for colon tests before. So we go to a sigmoidoscope. Sigmoid is a from your anus and rectum, and then ascending, transverse, descending colon, and it goes to rectum. So rectum to this descending colon, that shape looks like S shape. So remember this S shape, many times we call it as a sigmoid shape. So that's why it's a sigmoidoscopy, and the length is from the anus. This you need only about 10, maybe 50 centimeter. That's why sigmoidoscope is a rather short. Okay, and I actually brought it today for you. This is a sigmoidoscope. The length from here to here is actually 60 centimeter. And I'll show you a little bit more like when we get into the colonoscopy. All right, so that every 5 years is recommended. And technology-wise, computed tomography, you know what CT is? It gives a three-dimensional, and even the CT can be used, especially like giving a contrast for this X-ray. X-ray has a poor soft tissue contrast, so you need better to provide a contrast And I've done this kind of similar one with the barium anemia. So barium is an element which has a pretty high, it's a heavy metal. So X-ray, this could be a very good contrastation. So you drink, you drink barium containing, and then it coats in luminal part of the colon. And then you use X-ray CT, and it reveals the internal luminal shape of the colon. See if there's anything like polyp existing or not. So that's a barium anemia. And colonoscopy. Of course, colonoscopy is the kind of a longer version of this sigmoidoscope, because remember your colon, ascending, transverse, descending, and then rectum. This length is about, for adult, 1.5 meters. So including those machine to reach there, colonoscopy is actually length is almost about 2 meters long. It's pretty long. All right, so that's how things work. And so what are the current status? A couple of years ago, New England Journal of Medicine showed that there's now stool testing for DNA testing, and that can be very accurate. So that's what I heard recently, that even maybe not this imaging, but from based on stool, these DNA testing might be even more accurate and provide a better screening. So that, I don't think it has happened yet as a routine clinical practice, but I'm pretty sure sooner this will change. The way we actually screen, which one comes first, which one's cheaper, okay? Because still this colonoscopy has a risk. You have to have undergone many times a general anesthesia and all sorts of this. Okay, and then a cervical cancer is a cancer in the arising in cervix of a female. So they're called a pap smear, which is the entrance of the cervix. We use something like a tool. You swipe the entrance to scrape out cells there, because that's where cancers are usually arising. And then you spread it onto a slide, and then you stain it, and you doctors watch under the microscope to see if there's a cancerous cells or not. And also the other way is to watch the entrance of the cervix with the examination with an imaging. So that we call colposcopy. So that's for female. And what about male? There's a specific organ called prostate. Okay, so prostate cancer is a cancer which is actually relatively big for a male population. The problem is there are certain tests for this. For example, PSA test. What it stands for is a prostate specific antigen test. Okay, so this, what it means is that the level will go up if the patient has a prostate cancer. The problem here is, while high PSA level doesn't necessarily mean that this male patient has a cancer. So this is a problem, okay? So that means even if the name is specific antigen, high PSA level does not specifically meaning that you have a cancer. What it means is, for other reasons, can also elevate the level of PSA. So that's the problem. So that's why it's not recommended routine prostate cancer screening around the age of 50. So the practical issue of prostate cancer for male is, there's a statistics that for male, you hear like your grandfather, daddy, while the male gets older and older, and there's more of an issue of prostate hyperplasia, and that makes the urination a little more difficult. And some statistics say male, when the age of 80% of male has a prostate cancer. So when you are going into the hospital, let's say your grandfather, age of 80, go to the hospital and the doctors find out PSA test high elevated, and also so there's a cancer in prostate. do they have to undergo surgery or not? This is a real question, and in general, we don't want to have a even if it's cancer, you decide you have to really have an ethical and important practical decision whether we have to undergo invasive surgery or not, because in the end, that age people may not live long enough. If there's even if you try to do cancer therapy or surgical resection to remove, it may not make the patient live longer. So that is an important question. And while in general, prostate cancer is general more slowly growing and a little less metastatic in that aspect. Of course, once it gets metastatic, it can be more dangerous. So there comes not only whether PSA positive and even cancer exists, the treatment procedure or plan depends on the patient age and body state and many other things involved. So that's, I want you to understand that aspect. Also, lung cancer patient, lung cancer is, it's actually in terms of cancer, it's a top killer, it's metastasizing, it's very bad, but I think it's not very easy to treat, okay? CT scan is a method, especially, but we are not doing CT scan for screening lung cancer in general because it's not that specific yet. And so for those who are like heavy smoker for decades, we probably recommend to go to CT scan to check out your lung. Okay, and the last one over here is the ovarian cancer. Ovarian cancer is like a very notorious that it's a kind of silent cancer, because what we hear a lot of times is, hey, someone got ovarian cancer. That means already it's in general too late, because the tumor in the ovary doesn't give much symptom. That is an issue. So when by the time you get a symptom, many times it's already too late. Okay, so these ones are really a problematic, and I think Euiheon is supposed to present that ovarian cancer gene today. So there's a very famous ovarian cancer, breast cancer, BRCA gene 1 and 2, and it's for checking out the ovarian cancer. There's a blood test or ultrasound. While you see the location of ovary is a deep inside the belly, so it's not very easy to even for ultrasound imaging. So that's why I put it not very accurate. Okay, and not all female will get ovarian cancer, so screening is not recommended for women if there's no family history of ovarian or breast cancer. So hopefully this one makes sense. And also ovarian cancer, there's like blood testing, like PSA. I think it's I forgot the exact name, CA 125. There are like blood tests. That test is also not very specific. So, and it costs, right? So it's not recommended for every female to get this ovarian cancer screening. So that causes also a problem. If there is someone who have a progressing ovarian cancer, in general, it's very hard to find, and until the patient got symptoms. So that's still a big issue. And so let's.
교수님,
네. 네.
그 PSA는 지금 50세 이상에서는 1에서 2년마다 검진을 하도록 권고하고 있습니다.
Okay. Thank you, Euiheon Chung. All right, so this one's actually coming more from the US. So what from Euiheon Chung say, more than 50 years old, 1 to 2 years, PSA testing should be done. Thank you, Euiheon Chung. I'm not yet 50, so I don't actually have seen this recommended to me. But it's a good suggestion. Thank you for the correction. Okay. Right. Underscore. Good chart. Okay, so let's get into a screening test. So, this is where technology actually needs to for prevent cancer from arising. Okay, so cancer screening. So mammography is essentially 2D X-ray of the breast. Okay, so with the physical breast, of course, there's a physical examination because breast cancer usually involved with a mass in the breast. So you have to kind of using palpation to touch, and physical exam is probably the easiest and the first thing to do for screening for early breast cancer. But this mammography is looks like this, and there's a compression plate and cassette plate, X-ray tube shine, so that you can see from the top to bottom these 2D compressed breast images. While you have to have a trained eye, like otherwise in normal eye you cannot see whether this is tumor or not. In fact, here the left side is a normal breast, right side is actually there existing a tumor mass, which is actually over here. Okay, so this is an example of mammography, and the issue is it's not that accurate. What I mean is mammography has about 10% of false. What it means is, like this, maybe some doctors say, oh, there's something like mass here. You have to do more invasive procedure to check it out. So from mammography, this is also, let's say, positive. And then it turns out that it may be not. So let me see. Jibam?
Yes,
Can you say what missed cancer in this case? First, you can have either negative or positive.
Positive.
Yes. Sorry about that. Look at that. So here, what I wanted to say is mammography, it's the limitation of this mammography screening. 10% of false negative. What it means is, hey, if there actually was a cancer, but this modality is not sensitive enough so that you miss the cancer 10% of the time. What that means is, even if you went to mammography and you've got negative decision, that doesn't necessarily mean that you do not have cancer. Okay. So, for like cancer, which can be, life or death, fatal issue, this high level of false negative is actually a little problem. Okay, so you probably need a better way of screening method. Okay, so the next is the endoscopy. So I'm gonna show you about the colonoscopy. So you already know ascending, transverse, descending, and this rectum, this sigmoidal shape. And how do we screen colon cancer? Which I think Suyeon already showed a very well in her Q&A session, the rise of a polyp. And polyp is initially it's a benign, then it's not cancer yet, but there's a more chances for this one become cancer rather than flat normal place to become a cancer. So because of that, colonoscopy can be used. And what it shows is you can see this like protruding part of the small tissue mass, and that we call a polyp. You have to know this term, polyp. And once the gastroenterologist find this, what they do is they give a snare to check that out and take it out, and then send to pathology to see if it's a benign or it can be dangerous one. Okay, so I brought this one. I think I'm going to change my screen. Let me see. Okay, stop share. Stop share. Let me show my video into this. Okay. So I think this would be a good way, at least, to show you this this one, I have been researching this for years before, so I do have a colonoscope, a sigmoidoscope. So this part is going into the machine and that sends out the signal, okay? And while the other part, okay, the other part is this one gives a light source, okay? And this one a gas. And also, so that part goes to the, okay. And this part is what the gastroenterologists use for navigating the sigmoidoscope. You see this one says a number over here. This is 60. So this is 60 centimeter from the tip. Oops, sorry. So, and how does it work? So you see this one and this lever. So you use the colonoscope is to grab this and then use thumb to rotate this. So look at, let me try. You see X and Y, okay? And then the other one, I grab it. So you look at that, 1, 2, and then this one, ups, down, and left and right. So this way, while you can actually going in and navigate. And what's in front, I want to show you here. You see the middle one, that's a camera. There's a 2 ups and down, whitish one, and that is a light. You know, inside body is dark, so you need a light, a lamp which shines, and this is a camera. And the other part here is actually a side of flushing. So water irrigation. Irrigation goes to clean up the site, okay? And also you can find a hole over here. I don't know if it's clear to you or not. It's hole, and that hole is where the instrument goes in and grab this polyp and then took it out. And so this is an instrument channel. And where does it go? Is actually here. You see there's the instrument channel. It goes in to comes out of this. So this is how it works. And I hope so this, and it's in my office, it's in my laboratory. So whenever you're curious, you can come to try it out or anytime. One thing, engineering challenges. So when I discuss with the physicians who actually does this as a job, gastroenterologists, nowadays many more doctors are female. They complain that this is too big and too heavy for her to use it. So this is another, like, you know, the feedback. The doctors say, hey, we do need a more thinner, smaller, a lighter one for female doctors. Wait, that's something I wanted to share. All right, so let me go back to my screen. Okay. All right, so let's change my camera. Yeah, so that's endoscopy. The real issue, by the way, is another issue is this. You see when you see your shape of a stool, sometimes you see this undulation that is coming from this fold structure. So if tumors are rising at the backside of the fold, you may not be able to see. So especially when this is ascending column has actually bigger fold because they have to push this stool. So they have bigger fold. So when you go from the top to bottom endoscope, you may miss the other side of the fold. So because of that, people develop like spy endoscope, which has not only showing this, it shows like 180 degree to see on the backside of where you are going. You also see on the backside as well. So this is something like engineering solutions for the problems, so that you don't want to miss any remaining polyps, which is at the backside of this fold. However, these ones are all in about the colon. And what about small intestine? Yeah, this colonoscopy cannot get into the small intestine. So what if the problem is if there's a tumor or internal problem, that some patients, or you can find your stool covering with the blood, then you can actually suspect or something's going on within my gastrointestinal tract. Okay, but in general, like bright red color of blood means that the bleeding may come from your anus or rectum and close part. But if bleeding happens more deeper inside, what you will find is already a dark brown color. So depending on the color, you can actually see something's happening, something you may have to suspect, you may have to go to hospital. But another issue is if the rest part of GI tract, you have no access, that is a problem. So there, people have developed this a capsule endoscope, which is like a pill you can actually swallow, like this pill, which weighs less than 4 grams, and you swallow it, and it goes down like digestive tract, and it takes about 8-hour journey through the body. During the time, it takes pictures of inside your GI tract. So this is another innovation. I haven't tried this yet, but I think it may change the way. The reason is in the US, colonoscopy costs about $4,000, while this pill can cost only about $500. I guess it may be disposable, or it may be reusable. But so from engineering point of view, this technology allows us to see inside a GI tract throughout, and how things and what can go wrong. So this one has, you can see the technology makes it possible because of tiny LED array, and also CMOS camera, CMOS image sensor, which allowed 4 to 5 frames per second. So that's 4 to 5 times frames per each second. For your movie, it's about 24 or 30 frames per second. When you're a pro gamer, you may want even faster, maybe 60, 100 frames per second. And also not only this way, the other way. And you do need an antenna so that you can transmit the image information real time to the outside. And so that's an antenna. So, and that total one, also you need a battery, okay? So to allow during the time to actually perform this function. So I just given one example. Why is it good for? What is there any example that this capsule endoscopy might work? Okay, there's a case that bleeding issue, but with colonoscopy you can't find any suspicious. So use this one, actually detecting duodenum. Okay, so it's in first part of small intestine. Bleeding can be found by capsule endoscopy. So this is an example that, or you have problem, maybe not only in the colon, but elsewhere, you can identify and you may do some intervention, medical intervention for this. All right, so that's for colon. And now I want to go to a little bit of the breast cancer. So breast cancer is so it's very important, especially for female. And this is a good example of how a carcinoma or cancer arising from the epithelium works. So breast, the role of breast is a milk production, okay? So for that, there's a duct and there's a lobule. So lobule is composed of milk producing gland cells. And duct, you need a duct going through the nipple so that the baby can actually eat the milk. So cancer can arise either this duct or in the lobule. So we call it ductal cancer or lobular cancer. Okay, what about, let's look at the duct first. So duct is this ductal wall. Of course, there is a basement membrane. There's epithelial cells. It's normal. But cancer is not just like dichotomous, like normal cancer. There's a progression, so you have to understand how things work, and it takes over years sometimes. Okay, so you will find some abnormal cells arising. So some epithelial cells go strange, and they become abnormal, which means it starts to grow, proliferate, and that's called atypical hyperplasia. Sorry about all this jargon, but I think you have to understand jargon. Hyperplasia means the number-wise gets more, while the cells are not necessarily strange yet, okay, the appearance. So I put this dotted line up here. The reason is once it becomes this, you see, this is a cartoon doll, but it means it's now the cells are also strange. So it's cancer-like, looks like cancer. So cancer cells inside the duct. So they grow a little more crazy. And that location we call in situ, meaning that things happening at its original place. Because inside duct, things are happening. And usually what you find here is now it's we call it malignant. Why? And it now can start to invade. It can rupture the basement membrane, and it can have reach to the blood vessel downwards nearby. So cancer cells break through the ductal web. However, I have to say, imagine practically, you can't really find it very easily by just sampling. Okay, so once you find this, you are now, people will talk to you that it's a malignant state. Why you don't have evidence yet. But if it goes down through the body and elsewhere, if you happen to find metastasis, definitely it's a metastatic cancer, and that's a dangerous place. So here I say in situ means its original place. And in this case, we call it CIS or carcinoma in situ. Okay. Why carcinoma? Because this arises from epithelial origin. Okay. Neoplastic or cancer cells proliferate in their normal habitat here. So that we call carcinoma in situ. And so how do we screen or how do we diagnose breast cancer? So let's say someone undergo mammography. Hey, I found some mass over here. That's strange. Maybe you have to suspect. Then you need to go to a further follow-up study. Okay. So for that, now it's time to actually diagnose whether it's cancer or not, or if it's cancer, what stage it is. So, diagnosis is a term that we cannot say easily, because that is diagnosis means really figuring out and tell the patient, hey, you've got this cancer of stage number 3. How can you do that? We cannot say without a good evidence or gold standard. So that requires actually taking out the tissue, looking under the microscope, and the pathologist have to say, okay, so for that, we do, even if it's invasive, we actually do this tissue biopsy. Okay, what that biopsy means, small sample of tissue which are surgically removed so that the type and stage of the tumor can be determined. So I'm giving an example for breast tumor, breast cancer diagnosis, but this can be a little more general. So for example, we found a mass in the breast suspected area. Then there's a 2 ways of biopsy. The first is fine needle aspiration. Okay, what it means is you just give this needle stick to give it into the mass, and then you suck it, not with mouth, but with a syringe. Okay, you suck out the cells in there, that suspicious lesion, and then you spread it. You watch if there's a cancerous cells or not. Okay, so that's we call fine needle biopsy, but that we call, because of the sucking nature, we call it FNA or fine needle aspiration. Aspirator is like suction device. Okay. And so what's good about it? So it's easy because you just have this needle, a butterfly needle and flexible and syringe. So it's easy and quick. So you found something like cells which is strange, but you cannot tell which stage it is, because this one requires the actual morphology remain. Fine needle aspiration, you cannot distinguish whether in situ or invasive cancer. So if the cancer cells are localized inside the duct or it's already spread out, you cannot distinguish. So that's a limitation. So what you need is a way of biopsy to preserve its native structure. So what can you do? It's the second part is actually core needle biopsy. Those who know about like boring to find out water to make a well, in the past we did a lot about this. Or in the so that requires a really making a hole, but taking out the whole tissue in itself in this cylindrical shape. Okay, so that we call core needle biopsy. Of course, this needle is thicker than this because it's core needle. And what you do is basically you go in and you take out tissue of this shape, you take the tissue out. And then you can cut it and then watch under the microscope. Okay, so the core specimen looks like this. So that there's a cartoon to showing that. Fine needle aspiration versus core needle biopsy. Fine needle, you just like drip this, you just look at the single cells. While core needle, you insert in this way, the other way, and you take out that tissue cells, and then you cut them, and then look at under the microscope. So why do we also need core needle biopsy? Because when you need a more definitive clue that whether it's inside of cancer or already invasion has occurred or not. So more definitive histologic diagnosis, and so that you can actually distinguish the status of the cancer. And in theory, the problem is risk of seeding the needle tract with the tumor cell. Maybe during this procedure, if there's a cancer cell can shed along this needle tract. That's just a theoretical, but I hope this one gives you some idea. Of course, this is painful. There's a limitation of sampling error. What if the cancer is there, you just biopsy the other side and you tell the patient, hey, you have no tumor, no cancer. So that's about the breast cancer. And I want to move on to the next part of presence of cancer. And this is about a big portion of a female cancer called cervical cancer. And I have to explain that. So from this anatomy, so you now understand the category of epithelial tissue, which I focused a lot in the previous time. So look at this anatomy. This is uterus, okay? And this is cervix, and this is vagina, and the tip of this entrance of cervix. What matters is in this space, vaginal wall has a flat squamous cells, okay? While inside this cervical canal, the cell type is different. It's columnar cells. So what happens is, as I said before, at this junctional site, the cells usually have a little more non-stable phenotype of DNA. So that's where a lot of cancers are rising. Okay, so I have this one, squamous epithelium, which is more like this part, and columnar epithelium in the cervical canal. And so that squamo-columnar junction, this is the part where a lot of cervical cancer arises. So that's where what's a dangerous place. So this we call as a transformation zone in the cervix. Transformation zone is not only in the cervix. Another example I already told is a gastric stomach and the esophagus. So esophagus and stomach, that junction, stomach has a columnar, esophagus has squamous epithelium. So that junction, if there's a reflex, you know, like acidic reflex happens, and that junctional part to become more unstable. That's where esophageal cancers mostly arise. So that part is also a transformation zone. especially here, squamo-columnar junction and esophagus stomach junction. So we know from the statistics already, this is the part which is suspicious. So how do we actually diagnose? First, colposcope actually look through the shape and the color of this entrance of the cervix. That's a way to give a clue. And also send a QT, okay, or like more proper tools to scrape it at this junctional part, and then you spread onto the microscope slide and then stain. So this you can see. This is called pap smear. The pap is the inventor of this technique. The doctor's name is Papanicolaou. Okay, and in short, we just call it a pap smear. So look at this left side. This is normal, and this is a cancerous abnormal. So, you know, even this is a little more too striking to show you that this is a tiny nucleus compared to the cytoplasm. Compared to this is abnormal, much bigger nucleus. So, you know, there are ways for pathologists, or now AI will do the job in pretty near future, I guess. So nucleus cytoplasmic ratio, or NC ratio, is a clue. Another also clue is the shape of chromosome. So chromosome is condensed, dense chromosome also give a clue, and also mitotic index. How many cells actually have two nuclei or in the process of mitosis? Because the epithelium do not normally have too many mitosis, but cancer by definition, there are many mitosis happens. So there are you know, a number of more for figuring out whether this is cancerous cell or not. That's really a specialty of pathologists, but I think you know basic concept for that. Okay, so cervical cancer, we do pap smear, or it's called cervical cytology, meaning that cyto means cell. So here, because we spread, we don't see the tissue structure, but we only see the cell, okay? But we know where we took it out. So this one provides a very good clue to diagnose breast cancer, and colposcopy is this true imaging. So, so this is cancer screening and diagnosis, and I'm going to move on to the grading and treatment of cancer.